This year we thought we would keep a drug agnostic discussion of what is relevant for patients. And I thought one of the key takeaways for me is we've always relied on Soliris, eculizumab as a safe drug in pregnant PNH population. And there is emerging data which was presented showing that ravulizumab ultomiris could also be effectively and safely used in pregnant patients with PNH. This is preliminary early data, but it's reassuring to know that there could be other drugs in this setting.
Well, thank you, Austin. I also thought interesting about this session the importance of uniformizing the definitions you use in clinical setting and in clinical trials. For instance, what I call breakthrough hemolysis might be slightly different of what you call breakthrough hemolysis between the French system and the UK system. And that might impact patients' and clinicians' decision in switching or not patients from complement inhibitors. So I think that this international effort of working together to establish guidelines that should appear soon might be very interesting and useful for the international community.
The other thing, I don't know what you felt, now we got plenty of approved drugs, which is fantastic for patients. So I thought we had a nice discussion around what drugs do you use safely for which patient, how do you safely change from one drug to other drug, which is going to happen in real life for patients. It's fantastic we got so many drugs, but we need to also make sure that we effectively change from one to the other from an aspect when patients' clinical situation changes.
Yeah, that's an excellent point. Changing and not increasing the risk of thrombosis and breakthrough hemolysis, that might be a challenge in the real life scenario as well.
It is important. So like we said, quite a lot of options available, which is great for patients, and options with different modalities of action, how they work for patients, and more importantly, how each drug is given. Either it's given as a tablet or an injection. So I think patients being aware of available option helps that ongoing discussion. We always say this, is that although we switch between different drugs, it's good to get the right drug for the right patient at the right time and keep them on that drug so that the patient derives benefit.
Indeed, one major aspect of PNH treatment is patient's adherence. So if we indicate a treatment that is not convenient to a patient lifestyle, of course that will affect negatively the outcomes of these patients. But I would add as well, because all drugs are not available in first-line setting in different countries. So that as well should be taken into account in patients' and clinicians' reflection about starting PNH treatment.
So I think this is very interesting. We always relied on number of different medications. We talked about expanding. So there was this discussion today saying, like, where do we go next? I.e., we've got more drugs than patients, and there are now newer therapies coming through. So we were talking about a cure for this patient population without needing to be on this lifelong medication. I know we are nowhere there, but that's probably an ambition for us as a community to look forward to say whether we can effectively cure this condition without obviously needing the only curative approach, which is a stem cell transplant, which has got complications and risks associated with it.
We have also discussed about the drug prices and the need of establishing strategies so the drug could be accessible to all patients that need them.
Yeah, expanding access to countries which don't have access. And I think one of the things which you're touching upon is this initiative from IPIG, which is the PNH interest group, trying to bring in these drugs to countries or the global audience so that they can have the same access as other countries which has got all the medications for PNH.
And I'm really curious about this initiative because some drugs need blood infusions, IVs, and hydration, and some patients might live quite far away from medical centers. So perhaps the way of drug delivery, if it's sub-Q or oral drugs that might affect as well drug delivery to patients living far away from medical centers.
The Global PNH Registry is a fantastic initiative done by the AAMDS Foundation, which is very much patient-focused. The patients put in their information, what treatment, their symptoms, quality of life. And this is a rare disease. And although there are registries which are physician-driven, a patient-driven registry like this is very important because we learn quite a lot of things predominantly associated with the quality of lives. And also this important thing where the dynamics patients are changing between different treatments. What is it from a patient perspective that drives a change, which is done in conjunction with the patient and the physician. So I think this is going to add value to the physician-directed registry, and this is, I definitely think, will add more value down the line.
And being a patient initiative registry, it adds on the validity of the data, because the data we have today is chiefly driven by major centers that are already experts in PNH, and a patient-driven initiative like that might be much more representative of the real PNH population.
Yeah, so I think from a registry perspective, it's great. This is the first patient-directed registry for PNH, so I would encourage not only you, but other PNH patients to be enrolled, but not just enrolled, but frequently updating the data periodically as it stipulates in the registry, so we can get a very good overview of the data.